So I request the first student to please present this case.
Yes. So this is a bone marrow aspirate. It shows hypercellular bone marrow.
Perfect. So the bone marrow is hypercellular. What do you see here?
Okay. These are large cells with polymorphic nuclei. They are megakaryocytes. They are dysplastic with hypolobation, and some are monolobated or non-lobated with purple.
Okay. So just a second. We're going too fast. Let us start with this corner. So this particular. Let's go in a clockwise direction. So what do you see here?
Increased number of megakaryocytes.
Perfect. Okay. So what do you see in this image here? These two megakaryocytes. Would you like to say anything about them?
On the right one is a small size, non-lobated nucleus, and yes, it's micromegakaryocytes with.
Perfect. Very good. And what do you think is happening with this megakaryocyte?
It's also micromegakaryocyte and non-lobated nucleus, and I can see the granular cytoplasm.
All right. So that's a great point that you made. That as compared to this megakaryocyte and this megakaryocyte, these megakaryocytes are small, they are mature, and they have very small nuclei. They're almost the size of almost the size of promyelocytes or slightly larger than promyelocytes. So these cells are abnormal. They are micromegakaryocytes. This megakaryocyte, of course, is normal, but the point is that this nucleus is hypolobic. All right. So we'll move on to the next slide. So what do you see here? Start from the left.
To the left, I can see, let's say, full maturation spectrum of granulocytic lineage, and I can see occasional blast cells. Okay, you
can see full maturation. I like your wording. Full maturation of myeloid lineage, and you can see blast cells, like you can see here. All right. And any special cell you think this is?
This is basophil.
It's a basophil. And what do you see on this plot here?
On the right side, I see also blast cells and neutrophil. This is this myelocytes. There is most of them are blast cells, and I can see lymphocytes as well.
So you can see these blast-like cells that you are alluding to here. This might be a type 3 blast or a promyelocyte, and you see these spent nuclei. All right, these are the nuclei, probably burnt out nuclei of megakaryocytes that we are seeing here. And in this particular thing, nothing special. Same thing all over. And what do you see here?
These are basophils, and this is a genetic precursor.
Perfect. So you are seeing basophilic cells here, and mature basophils and eosinophilic precursor here. All right. And we can see that there are blasts here, and these cells that you see here. And would you like to comment on what's happening here?
This is a myeloperoxidase stain which is negative. Yes, negative
which is negative in the MPO, which is negative in the blast, and these are all your control myeloid cells which are positive, and you know that the stain has worked. All right. So what do you see in the flow cytometry?
Okay, CD34 is positive, medium, 42B is heterogeneous and positive, 117 is negative, HLA-D are positive, some population showing some positivity of 117. It is positive for 13 with moderate, medium to moderate, and 38 is positive, moderate. CD7 is positive, and it's heterogeneous expression. CD45 is moderate, 33 is positive dim, and 123 is negative.
Okay, so you're right in your interpretation. Only we should be thinking about how the intensities of these antigens are called. So typically, when you want to call intensities of antigens, these are done in reference to what is normal. All right. So you should know where normal antigenic intensities lie for your instrument. So I'll tell you that this HLA-DR is a spectrum right from negative to positive, and this would be called as variable. And only a small subset of these progenitors express 117. So we'll say this is subset expression. Now this 13 and 38 are both dim to negative. Only a small fraction of this is positive. So I'll say dim to negative. And CD7 is variable. Okay. Again, 33 is dim to negative. So coming back to this question, do you think that this CD7 is a normal phenomenon or abnormal?
It is aberrant expression of CD7 because it's a T cell marker, T cell lineage marker.
Yes and no. So you are right. Such a big or such a large population of CD7 expressing myeloid cells does not exist in normal cells. But you must remember that a small subset of CD7 positive myeloid cells also exists. All right, and this is pretty much normal. So at this point, what do you think are the differential diagnoses?
So because the blast cells are more than 20%, we think of acute myeloid leukemia. So to think of the subtype, I'm thinking of two possibilities. Number one, with inversion 3 or translocation 3-3, because of the presence of organomegaly and dysplastic megakaryocytes. Number two is AML, BCR, ABL1, whether on top of CML or de novo.
Okay, so what do you think the investigations should be done at this stage?
So what I need to do is to look for these translocations and the fusion proteins with the conventional karyotyping and FISH study and PCR.
Okay, so you want to look for PCR, and why do you think this is important? Why do you think it is important to look for these changes?
In order, we need to precisely differentiate between these types of AML because with the presence of maturing granulocytic lineage and basophils and organomegaly, maybe it can be caused by CML and anaplastic crisis, and that will lead to treatment that would be different. We need to use tyrosine kinase inhibitors, and they will be useful in addition to other treatments.
So let us go by this step by step. All right. Now this patient has presented to you with leukocytosis and organomegaly. Now, if a patient presents to you with leukocytosis, organomegaly, blast, full spectrum of myeloid cells, and as well full spectrum of myeloid cells, increase in basophils and eosinophils, the first differential should be CML in blast crisis. And as you rightly said, you need confirmation of this diagnosis with additional techniques such as FISH or PCR. All right. Now, AML, we'll consider the rest of the diagnosis soon. So can you comment on what's happening here?
So this is a transcript identification for PCR, for fusion of BCR ABL1. This transcript, so I think this is another plot. Because it's transcript, I think this is another plot study or test. And it's showing, yes.
Yes. So what does this line show?
It says internal control.
Right. So this is an internal control for a gene called BCR1. All right. So there are many different ways in which you can perform testing. It is not important to learn that by heart because it can be done in different ways. But you can see here that we have a whole lot of controls here. So would you like to speak about what these controls are?
For example, the first one, which is E13A2, it is with positive result at the bottom of the.
So this E13A2 is positive here, and you can see a band of similar size in our case. So it is E13A2, and this patient is therefore positive for E13A2. All right. Now let us look at a similar case, which is case 1A, and would you like to comment on it?
Yes, sir. This is also hypercellular bone marrow.
Okay,
Hypercellular.
hypercellular bone marrow. And there's something else going on here which I would like students to know. See, the bone marrow is really hypercellular, but you can see that there is absolutely no cell trail. Okay, or there are few cell trails here. So this in itself is an abnormal finding. If you see hypercellular particles with poor cell trails, it means that there could be some degree of fibrosis or infiltration into the bone marrow. All right, so this is a soft pointer towards what's going on. So this is something to keep in mind. And what's happening here?
On the right side, there is a, I can see, cell on the right side, these are blast cells, sir. They
So
are
these
not,
are blasts, absolutely. What cell do you think this is?
this cell could be, I
Yeah,
think,
mhm.
maybe megakaryoblast or erythroblast, I'm not sure.
Okay, so it's an erythroid cell, all right? It's not a megakaryoblast. It's an erythroid cell. See the very sharp, perfectly round structure with a nuclear membrane, with a sharply demarcated nuclear membrane. These are typical of erythroid cells. These are of course blasts. What do you think these cells are?
They are also blasts, but they are different in size.
Okay, so these are normal lymphocytes, all right? This is for reference. So these are normal lymphocytes. You can see that they're much smaller in size. They're not blasts really.
Yes.
Okay, and these are again blasts.
Yes.
This could be a blast. It could be a developing B cell or hematogone. I don't really know what this is. Most likely it's a precursor B cell or hematogone. And again, you're seeing blasts. These blasts are MPO negative. And this is the flow cytometry for this patient. Can you comment on it?
CD34 is positive. Some population are positive for CD25.
Very good.
HLA-DR is positive, and CD13 is positive.
Yes, but it is really dim. And what else can you see here?
Negative on here, dim 13 and negative to dim 117.
Right. So it's dim to negative for 13 and 117. And again, what do we see here?
This is also a positive case for at the parallel with this. I can see that it is E14, A2.
Very good, wonderfully described. So you're right. So now the question is, how does the first case differ from the second case?
So in the second case, we didn't see a maturing, like the first case, maturing granulocytic lineage.
Okay.
So at the same time, it is the BCR-ABL1 positive. So I'm going with AML BCR-ABL1 de novo.
Wonderful. So you are right, and this is indeed the second case is indeed an AML with BCR-ABL1. But sometimes in the clinic or sometimes in your pathology practice, when you're seeing these cases, it is a more difficult scenario than what we are seeing here. So because it is really very difficult to distinguish pH positive AML from CML in myeloid blast crisis, right? So pH positive AML or AML with BCR-ABL1 is rare. It accounts for less than 3% of AML cases. Clinical presentation is typically there should be no documented history of CML, and splenomegaly is uncommon. What is unique about this is that you don't see basophilia in these patients. All right. So this is the largest series that was published more than 1.5 decade ago from the different colleagues. I think this is from Dana-Farber, and what you can show is that this was 16 patients, and virtually 75% of them did not have any splenomegaly, and very few basophils on the peripheral blood. All right, so this is one of the main differences that one sees between CML blast crisis and pH positive AML. Another large series, possibly the largest so far, is a Swedish population-based registry of 21 patients, which asked a simple question: how does the genetics of these disorders compare to that of CML and blast crisis? So you can see that these patients they around 50% of them had additional chromosomal abnormalities, around 50% of them had additional lymphoid markers, but which did not meet the criteria for mixed phenotype acute leukemia, and half of them are at least a quarter of them are P190 fusion transcript positive. All right, so this is something that is extremely unusual. In the case of CML blast crisis, you can virtually, a myeloid blast crisis, it is very, very rare to get P190 transcript. So when they perform genomics on these patients, they could identify that these mutations, amongst these mutations, RUNX1 mutations were seen in nearly 40% of these patients. The common mutations included IDH2, TP53, ASXL1, BCOR, and SRSF2. When they compared their data with other data sets, as well as patients who had CML myeloid blast crisis, they found that the genomics of these patients were actually quite similar. So most patients had RUNX1 mutations. Patients with either CML blast crisis or with AML with 821 had RUNX1 mutations, IDH1, IDH2, ASXL1 mutations, and it is really very difficult just based on the genetics to differentiate the two. This is another paper in Annals of Hematology which gives some sort of an algorithm. So if you have blast more than 20% and you have detection of translocation 922 by PCR or by FISH or by cytogenetics, and if the patient has an antecedent, that is a previous blood abnormality, and there is no dysplasia, you can consider CML blast crisis. If the patient does not have any history of an abnormality, but he has basophilia, you can consider CML in blast crisis. If there is no basophilia, you should consider BCR-ABL1 positive AML. If the patient is P190 transcript positive, it would again be suggestive of a BCR-ABL1 positive AML. And if there are only a fraction or a small less than 100% of BCR-ABL positive metaphases, it is again a soft pointer towards BCR-ABL1 positive disease. So what do we learn from this case? Number one, the distinction of CML blast crisis from de novo AML with BCR-ABL1 is difficult and it is rare. Even the new WHO says that this distinction should be taken by taking all these factors into account. One, clinical history, physical examination of the patient, and noting down of additional myeloid differentiation like eosinophilia and basophilia. And what thing to note is that genomics is quite similar to that of CML in blast crisis as in AML with BCR-ABL1. So with that, let's move on to the next case. So the next student can speak on this case, please.
18-year-old male with pancytopenia. Bone marrow is done for evaluation.
Okay, good. What do we see here?
So this is a hypercellular bone marrow with paucity of fat.
Okay, so you can see that the bone marrow is actually really hypercellular. And what do we see in this picture?
This is a hypercellular fragment with no fat present.
And what do we see here? Well, let's take on all these from clockwise direction.
This is a dysplastic megakaryocyte showing multinucleation and hypogranulation. The second one shows bilobate. It is also a dysplastic megakaryocyte. In the third picture, it is monolobated.
Okay, and in this picture, I'm sorry, this picture, when I think the file sizes were being reduced, it's turned like this, but I believe the PDF that has been circulated is proper. So this is also an abnormal megakaryocyte. I apologize for this image. And what do you think is happening here?
So this is also a dysplastic megakaryocyte showing hypogranulation and hypolobated.
Okay, so let me ask you, what are the features that you think are abnormal for megakaryocytes? Let's talk about this megakaryocyte. So what do you think is abnormal here? What would you label this as if you have to give it a name?
This is a micro megakaryocyte with 3 lobes, and the cytoplasm is not mature, hypogranulated.
Okay, so you keep mentioning that the cytoplasm of megakaryocytes is hypogranulated. There is no such thing as a hypogranulated megakaryocyte cytoplasm. All right, this is a micro megakaryocyte, which is perfect. It's small in size, the nucleus is small, but the overall cell size of as compared to that of a normal megakaryocyte is low, is less. So it is mature in nature. And this is actually, there's nothing like hypogranular cytoplasm for megakaryocyte. Same thing here. You're seeing that these are granules inside of these, and these nuclei are dislocate or separated apart. And again, these are very small megakaryocyte nuclei. Now, would you like to comment on what's happening here? What is this cell? Hello?
Plastic erythroid precursor with internuclear bridging.
This one at the point.
This is a megaloblastoid change with sieve-like nucleus.
This one at the one at the pointer here, one where the arrow is pointing. This is a megaloblastoid cell with sieve-like nucleus. Is that what you said?
Yes, sir.
So hang on a minute. If you were to give this a lineage for this cell, what would you say this is? What lineage would you say this cell is?
Erythroid lineage cell.
Okay. So if you were to say that this is erythroid, why would you call it erythroid? Let's discuss this for argument's sake. What do you think that is here in this that makes it erythroid?
So the nucleus is nuclear boundary is regular, and the cytoplasm is slightly basophilic.
So where is the cytoplasm for this cell? If I can ask, I don't see any cytoplasm to the cell. Where do you see it? Can you see this red pointer moving around?
Yes, sir.
Okay, so where is the cytoplasm? Can you please tell me to stop if you see the cytoplasm? I don't see any cytoplasm here. All right, you see this is a cell with cytoplasm. This is there. Do you think the cell is cytoplasm? It is there. But there is no cytoplasm in the cell, all right? So in a typical erythroid cell, the nuclear chromatin stains darkly. So you can see this is an erythroid cell. This is an erythroid cell. These are all darkly staining. This is an erythroid cell. Even if it's an early pronormoblast, early erythroid precursor, even then the nucleus does stain darkly. And it has abundantly blue cytoplasm because of intense RNA activity. See, these are cells that are trying to produce hemoglobin. And that's why their RNA activity is intense and so blue. But this cell doesn't have any cytoplasm. This is a myeloblast, right? Or a blast at least. Okay. What do you think is happening here?
Sir, in this is also a dysplastic erythroid precursor with internuclear bridging.
Wonderful. And what do we see here?
This is also a dysplastic erythroid cell with multiple nucleus.
Okay. And this cell?
So this is a normal erythroid.
So this is an erythroid cell, all right? But you see the nucleus, what do you think? This is almost got a sieve-like chromatin, okay? So this is a megaloblastoid change. And what do you think is happening here?
So this is also a dysplastic cell with bilobated nucleus.
And what kind of cell is it? What lineage is it?
Myeloid lineage.
So this is actually an erythroid, binucleate erythroid cell, all right? So these are binucleate dysplastic erythroid cells. What cell do you think is this?
So this is a monocyte.
Okay, so you know how to make this out. If you see the cytoplasm, do you think it is what on a scale of 1 to 10? How blue is it?
It is 4 up to grayish.
So a monocyte like we saw yesterday will have far paler staining cytoplasm. Right? This is really blue. This is like blue as in 8 or 7 blue. And such blue cytoplasm, as I mentioned before, intense RNA activity and dark, very dark staining nuclei. So this is an erythroid cell showing megaloblastoid change. This is the blast. See the chromatin differences between the two. This is what one would say is fine chromatin or open chromatin, and this is coarse chromatin. All right, dark blotchy chromatin that is there. These are blastic cells. What you see here. And what do you think is happening here?
So this is a neutrophilic lineage with pseudo-Pelger anomaly.
Okay, so yes, it is plastic neutrophil. It is hypogranular. I'm not so confident of pseudo-Pelger in this, but yes, I would say it is Pelgeroid at least. Okay, so yes. Now what's happening here? Do you know what this is we are seeing in front of us?
This is NGS.
Correct. But what do you call this image? So this is something that is known as an IGV plot, all right? It is a visualization of alignment of the genome with the reference genome. And you can, and every individual line that you see here is an NGS read. And you can see that there is an insertion of 4, this 4 that is written here. There is a 4 base pair insertion at this particular location. So this is very typical of NPM1 mutation. You have an NPM1 mutation, a RAS mutation, and an IDH mutation, all right? So at this point, what do you think the morphological diagnosis is?
Sir, there are 2 differential diagnoses. On morphological point of view, I will first say this is a myelodysplastic neoplasm with increased blast count. In this, 12% are blast. But considering the NPM1 mutation, the second differential would be AML with NPM1.
Okay. So how common it is to get NPM1 mutations when you have 10 or 12% blasts, or less than 20% blasts?
It's in AML, it's quite common. In 80% of monocytic leukemias.
No. So of course you're right. But my question is, when the blasts are less than 20%, how common is it to get an NPM1 mutation? So it's really rare, all right? It's okay. It's not a common thing to see at all. And what is the importance of this diagnosis, if I can ask?
Sir, if NPM1 mutation is present with AML, then it have a good prognosis. The patient responds very well to therapy. And there is the patient is exempted from an allogenic hematopoietic transplantation. It can be cured even with induction therapy. Okay, so lots of things happening, okay, in what you said. So let's go about the theory of this. So this is a paper that was published from Dana-Farber, which looked at one of the largest series, so 45 patients with NPM1 mutated myeloid neoplasms, which were not AML. And you can see that most of these patients either presented as MDS excess blasts or as chronic myelomonocytic leukemia, all right? And you can see that the follow-up was actually quite less. Median follow-up was about 10 months, and 50% of them progressed to AML. As far as mutations of these patients were concerned, that means NPM1 positive myeloid neoplasms, which were not AML, the mutational profile was actually quite similar to that of standard NPM1 mutated AML. So you had DNMT3A, IDH1, IDH2, TET2, the RAS pathway, FLT3 mutations, and so on. But it is important to
understand that means that the biology of these disorders was the same. But when you look at the outcome of these patients as compared to NPM1 mutated AML, it's actually same. It's actually same, or in fact worse than those patients with NPM1 mutated AML. So why is that so? So this is another paper that is published on not many, about 30 odd patients who were treated who had NPM1 mutated myeloid neoplasms. And you can see that when these patients, that means patients were treated as MDS. So MDS patients are treated with something called as hypomethylating agents. When these patients were treated with hypomethylating agents, their outcomes were worse. But the minute you treated them with more intense chemotherapy, such as either chemotherapy or hypomethylating agents followed by transplant, their outcomes improved. This seemed to indicate that these patients had a better or more favorable outcome when you treated them aggressively, and therefore it is important to recognize this disease. So this is an excellent review. I would urge all of you to take a look at it. It is a sort of a big review on all series so far of patients who had NPM1 mutations who were non-acute leukemias, or had less than 20% blasts. And you can see most of these patients presented as excess blasts or as chronic myelomonocytic leukemias. Okay, so based on these findings, the WHO has now said that these patients should be treated with that irrespective of the blast count. Any presence of NPM1 mutation is actually an AML defining event, and these patients should be treated. Should be recognized as AML irrespective of the blast count. So what do we learn from this case? That NPM1 mutations are now diagnostic of AML irrespective of blast counts. Patients with less than 20% blasts have a morphology similar to that of MDS-EB or CMML. Their outcomes are similar to AML and must be treated with chemotherapy or bone marrow transplant rather than hypomethylating agents. So let's look at the third case here.
It's a 39-year-old female with gum swelling, fatigue, neutropenia, and thrombocytopenia.
Okay, wonderful. And let's go on to the next slide. What do you see here?
We can see a bone marrow aspirate, which is hypercellular for age. In second picture, we can see the megakaryocyte, which appears to be normal, surrounded by granulocytic and erythroid lineage. And in third picture, MPO is focal positive, sir. And fourth picture, we can see focal positivity to MPO. Fourth, we can see blast cells. These are polymorphic nuclei with irregular nuclear contour, moderate amount of cytoplasm, agranular, and chromatin appears to be fine lacy-like chromatin. Also, we can see 1 or 2 cells with prominent nuclei, and also some cells, 2 cells are which are having vacuolated cytoplasm and lacy-like fine chromatin abundant cytoplasm, and appears
so
to
it's lace-like chromatin. All right, there's nothing lacy-like. Lace is fine material. It's old school English, but lace-like chromatin is typically seen in
monocytes.
Do you think these are monocytic lineage blasts?
Yes, it appears to be to the myeloid as well as monocytes.
So I do think they are myeloid, but I'm not so convinced about their monocytic nature. All right, you must remember that even AML M0 is MPO negative, and these cells have actually very little cytoplasm for them to be monoblasts. All right, and their nucleus is open. Some of them may have some monocytic features like this. Guys, irregular nuclear margins maybe, but for the rest of them, I don't think so. I'm not very convinced that these are monocytic lineage in nature. Okay, so what do we see here? What's happening?
In flow, we can see CD45 is weak positive, and CD117 and 34 is dim positive. CD123 is also dim positive, and CD33 is negative. CD15 is weak. CD45 is weak, as well as CD15 is also weak positive.
So you're right about positive and negative, but the intensities need to be taken into account. So this is dim to negative, this is also dim to negative, this is variable intensity of CD34. Okay, and these are all blasts that we see here. So this is next generation sequencing. Would you like to speak about this?
There are fusion of genes of rare genes EXH2 SMC1A having variable allele frequency of 49-48%, along with IDH1 and NRAS mutation is also present. So it is like a fusion protein translocation.
Okay, 1 second. So where did this? You're right in that these are NGS and they are mutations, but where did fusion come into play? Where's the fusion bit in this? How did you arrive at the fact that there's a fusion?
The translocation chromosome. So exactly, I could not predict much on NGS.
No worries. All right. So this represents the gene. This represents the address. You know how we say pin code I stay at 400706. This is the genomic address that is there of this particular gene mutation. This is a nucleotide change. The C is changing to T, and every gene has got multiple transcripts that are there. So there is something that all biologists agree on, that okay, for clinical mutation calling, we'll all refer to NM4456. So when you talk of that particular gene and you say NM4456 in the exon 17, you have a C to T change at the particular base address of 1978, where the G is changed to an E. Okay. So again, the protein that G changing to A means G changing to R. All right. And these mutations are there. So what is the implication of these findings? So number one, what is the hematologic diagnosis?
So acute myeloid leukemia with undifferentiated, or can be, if we can see some monocyte variant also can go into.
So we went through this in the previous lecture. If you have to see monocytic lineage, what are the other things that you must see? How do you assign monocytic lineage in the blasts?
It should be NS non-specific esterase positive.
Wonderful. So these blasts should be esterase positive. If they're not, if you don't have esterase, or you what else should they show?
So by flow, also we can identify markers like CD64, CD14, CD11B and 11C should be positive. Any 2 of these markers should be positive.
Right, nearly right. It's CD64, CD14, CD11C, not 11B, and you forgot about 36. So all of these should be expressed brightly. All right. So did we see any of this?
The 64 is my.
Yeah, but it wasn't bright. 64 comes in granulocytes as well. So it wasn't bright, all right?
No, sir. Yes, sir.
Okay. So this is just an AML without differentiation. So does the NGS result influence the prognosis here?
So it influences the prognosis, but it has not. So because we have seen in NGS, there are genes which are having.
So in the particular patient, in the particular set of mutations we had, what do you think is important in this? It's okay if you don't know, say you don't know. It's fine.
Sir, I don't know.
All right, no need to worry about it. So what's the importance of this diagnosis? Let's look here. All right, so this patient has an EZH2 mutation. What is the implication of these findings? So let us look at a seminal paper. This was published in Blood in 2015, which looked at 194 patients, out of which 93 had gold standard secondary AML. So this is a very well characterized cohort where they had histopathological documentation of either MDS or chronic myelomonocytic leukemia. They followed these patients up till they had secondary AML, and they studied the genomics of these patients. They had 101 patients of therapy-related AML. That means patients who had a history of cancer chemotherapy, and 180 patients of otherwise de novo AML. And they looked at the genomics of those patients. And what you can see here is there are 8 mutations that actually stand apart: SRSF2, ZRSR2, SF3B1, ASXL1, BCOR, EZH2, U2AF1, and STAC2. And if you have mutations in these genes, they said that you had a 95% specificity of secondary AML as compared to de novo AML. All right. So this brings us to the diagnosis of AML with myelodysplasia related changes. We went through this previously, and I'm going to go in the previous talk, and I'm going to show how AML with MR is diagnosed when you don't have actual cytological dysplasia. So if you have blasts more than 20% or less than 20%, if the blasts are less than 20%, straight away it is MDS. I mean, it's not actually AML-MR. If the blasts are more than 20, the patient has past history of chemotherapy or radiation, then you can't say AML-MR. If that is not there, if he has a previous documented history or MDS or MDS-MPN, then it's AML-MR. If that is not there, and all of these abnormalities, that is recurrent fusions as well as NPM1 and SEPA mutation, are ruled out, that means AML with recurrent genetic abnormalities are ruled out, and there is dysplasia in 2 or more lineages, it is AML with MR. If dysplasia is not there, like in this patient, and if you have any of these cytogenetic abnormalities or somatic mutations, it still becomes AML with myelodysplasia related changes based on the previous paper that we saw. All right. So the new WHO classification says that AML-MR is a neoplasm with 20% blast with either a specific history that this patient has MDS or MDS-MPN and now has become AML, all right, and with cytomorphologic dysplasia in 2 or more cell lines. But cytomorphologic dysplasia may or may not be there. If it is not there, you can see mutations in any of these 8 genes and you can still say it is AML-MR. So there are criteria that are there, and you can please remember these criteria. All right. So requires that the patient should have more than 20% blast, should have history of MDS or MDS-MPN. If not this, he should not have history of cytotoxic therapy, history of MPN, other genetic abnormalities or criteria for myeloid neoplasms with germline disposition. And you can get any of either cytogenetic or somatic mutations and still this becomes AML-MR. So what do we learn from this case? That AML-MR can be diagnosed on morphology. It can be diagnosed by detecting specific molecular or cytogenetic abnormalities irrespective of dysplasia. And most importantly, this is a common disease. Account 30 means relatively common AML, accounts for 30% of all AMLs and is predictive of poor outcome. Okay, who's going to speak on the 4th case?
Sir, me. Case 4, 55-year-old male, complains of fever, abdominal distension for last 2 months, and series shows anemia and leukocytosis.
Right, and what else have we got?
Sir, the bone marrow aspirate is particulate and cellular, and it shows
cellular. And what do we see here?
Shows large cells with moderate abundant amount of cytoplasm. With
what cell is this?
Sir, this is I think blast.
Okay, this is a blast with a prominent nucleus. It has got low NC ratio, and these what do you see here?
These are eosinophil precursors.
Eosinophil precursors. You have blasts. These blasts are what do you think of their
positive?
MPO positive. And do you think that the granularity of some of these cells is low, like what you see here?
Yes, sir. I thought there are some hypogranular and some dysplastic changes in the.
There are hypogranular dyspoetic changes. And what's this?
So these are also I thought eosinophil precursors.
Right. So there are eosinophils and eosinophilic precursors. And what's this?
This is an OR rod, sir. Single OR rod with peptide.
Okay, so blast with an OR rod. The OR rod is actually quite slim and trim. Okay, all right. So you have a blast with OR rod, and what are these cells?
Basophilic.
Most likely basophils. They could be mast cells also. Really, so many granules I can't make out anything. All right. So most likely mast cells. So what do you see here?
Sir, the blast are CD45 being positive, and CD34 shows positivity.
Okay.
And HLDR is also positive.
Okay, and, positive. And what is this? What is happening here?
CD19 is also showing some aberrant expression, sir.
And what is this?
This is some B cell lineage.
Very good. So these are normal B cells, right? And they're positive for 19. I can see that as compared to that, the CD19 expression is
right.
So as compared to B cells, this is generally lower. So this is, I would say, variable expression of CD19. Right?
Yes.
And what do you see here?
So HLDR is positive.
HLDR
is variable positive.
Okay.
And CD117 is also heterogeneous positivity.
Very good. All right. And what do we see here?
So here, sir, CD15 is negative, sir, in the blast.
Okay. In the blast, 15 and 11 both are negative.
11 is both negative, and MPO is positive, sir.
MPO is positive in the blast. And would you like to comment on this, on the granular site maturation here?
Yes, sir. It shows a normal maturation.
So there is some abnormal pattern with respect to 13, 16 and DR11. Okay, so there is some amount of abnormality that you see here as well as here. Okay, so there is asynchronous left shifted maturation. And what is this?
This is a fluorescent in situ hybridization showing fusion of gene. One is indicated by green signal, and other is red signal. Next one,
green is RUNX1 T1, red is RUNX1, and here you have
green is RUNX1 T1 and R is RUNX1, and it shows a fusion showing yellow.
Yellow color. So there is a RUNX1 RUNX1 T1. Now you are seeing NGS results. So what do you see here?
It shows a maximum frequency of allele frequency of 38.7% in KIT mutation, KIT KIT mutation, along with ASXL2 mutation, and there is nucleotide change from guanine to cytosine at exon 17.
Okay. So there is a KIT mutation. There are ASXL2. Both of these are what kind of mutations?
There is
there's substitution changes. All right. So there is substitution changes. And what is this?
This is deletion.
So there is a deletion between the bases 674 to 689, which results in what? What is this? Okay, all right, no need to worry about this. So there is a deletion that you see here. Whenever you get a deletion, what it means is that the reading frame of the amino acid. So at amino acid 225, there was a proline. Because of this deletion, that proline changed to arginine. It introduced a frame shift change, which results in a termination codon. That means you know what a termination codon is, right? TA, TAG, and that other one. So all 3 termination codons. So there is a premature introduction of a termination codon 94 nucleotides later. All right. So this is a description or an HGVS compliant description of a frame shift mutation. Okay. And this is again a base substitution. So which brings us to the fundamental. Okay, so all right, so you can see this. So as I said before, this is an IgG plot which shows a G to C change. Okay, in the D, that is the D816 that was there, GAC changed to CAC. Okay, so what is the diagnosis here?
So it is AML with RUNX1 and RUNX21, translocation 821.
Okay, and does the NGS have a meaning here?
So as you can see, KIT mutation is identified. So KIT mutation shows an adverse prognosis, which causes resistance to the conventional hydroxychloroquine and also decreased overall survival and recurrence-free survival.
Very good. And what about the rest of the mutations? Now that you're mentioning this, do you think mutations in other genes such as ASXL1 and ZBTD7A are important?
So I'm not sure about the prognostic factor, but in 20 to 30% cases, ASXL1 and 2, I think. Sure.
Okay, all right. So let's take a look. Okay, this is a spot case. It's a cousin of that case. 16% blast MPO positive. What do you think is happening?
I think there is some abnormal eosinophil with bluish purple granules.
So what cell is this? Let's go into it step by step. What cell do you think this is?
This is a blast with high H's ratio and
Very good.
prominent.
So it's a blast. All right, it's a blast. What do you think these cells are?
These cells are nuclear in irregularity and convolution.
Okay.
So maybe promonocyte or monocytic lineage.
Okay, so they are monocytic lineage. Excellent. So these are convoluted nuclei and that lacy like nucleus,
Yes.
like nucleus. What you see here is lace-like nuclear chromatin. Finely, fine nuclear chromatin, as opposed to this, which is dark and blotchy. All right. So fine lace-like chromatin. And what color is this cytoplasm?
Grayish blue.
Grayish blue. With what are these? Azurophilic granules. Okay, so these are monocytic lineage cells that you can see here. Now let's come to these cells. So what do you think is happening here?
These. So I thought some abnormal eosinophil is there.
All right. So these are
Those are
eosinophils with primary granules. All right. They are eosinophils with primary granules still present, called as eobasophils, and they are very characteristic of something. So what do you think is the diagnosis here?
It is AML with CBFB and MYH11.
Wonderful. So you're right. So this is an AML with CBFB, MYH11. So let's go about theory in this. All right. So if you look at the old school or the pre-genomics era classification of AML, based on cytogenetics, you could classify them as AML with favorable prognosis, intermediate prognosis, and poor prognosis. All right. Patients who typically came with favorable prognosis had AML with 821 or inversion 16, and patients who had a monosomal karyotype or complex cytogenetics, such as, sorry, my presentation switched off. I think Shalini or someone pressed sharing. I would urge you not to do that, please. All right. So if you have a monosomal karyotype, or you have presence of monosomy 5 or monosomy 7, or you have complex karyotype, it has a poorer outcome. Okay. But important thing to note is that this 821 and inversion 16 together were called as core binding factor leukemia. And for a long time, they were thought to be similar diseases. But are they really similar at a genomic level? So there is this nice paper that has been published in Blood Advances earlier this year on a really large cohort of 200 patients who of core binding factor leukemia with RUNX1 and RUNX21 and CBFY11. And indeed, you can see that these patients are on the face of it normal. They show presence of KIT mutations, RAS mutations, FLT3 mutations, and WT1 mutations. Especially KIT and RAS, these are called as RAS pathway mutations, all of them, and signaling pathway mutations such as FLT3 are shared between both these patients. Okay. Now this particular plot, does anybody know what the name of this plot is? This is known as an oncoplot. All right. In an oncoplot, on the every row is a gene, and every column you can see that every one of these two lines here that you can see is actually individual patient. So there are 200 of these small lines, and there are 200 patients. So you can see that patients with RUNX1T1 as well as CBFB-MYH11, they do have KIT mutations, they do have FLT3 mutations, and KRAS mutations. But if you see, there are a group of genes known as chromatin modifiers, such as ASXL2 mutations, and these mutations, ASXL2, EZH2 mutations, as well as transcription factor mutations such as ZBTD7A, are unique to AML with RUNX1T1. All right. Another change that we see here is loss or deletion of the sex chromosomes, deletion of X or deletion of Y, which is a very unique poor prognostic finding that is seen in AML with RUNX1T1. So you can see that on a genomic basis, these patients are superficially similar, but when you do larger panels, you can see that they have different kinds of mutations. Okay. Now, when they looked at mutational profile of these patients, you can see that patients with RUNX1 and RUNX1T1 had an inferior outcome if they had KIT mutations. This is known as a Kaplan-Meier curve, and you can see that every time this line drops, one patient gets an event. So here you can see that if a patient had KIT mutations, you are really likely to have relapse as compared to patients who didn't have KIT mutations. And if you looked at it, what kind of KIT mutation closely, you can see that patients who actually had exon 17 mutations did badly, but not the rest of them. All right. So they showed that KIT mutations predicted poor outcomes in AML with RUNX1 and RUNX1T1, and exon 17 mutations only were predictive of poor outcome. But this is debatable. But what the take-home message is that if you have KIT mutations, the patients with RUNX1 and RUNX1T1 do better. Now, when you look at CBFB-MYH11, you can see that KIT mutations actually did not predict outcome in these patients. Okay, so this is something to remember, that KIT mutations do unfavorably in patients with only in RUNX1 and RUNX1T1 and not in CBFB-MYH11. I apologize, my dog seems to be talking a bit too much. Okay, I apologize for that. Okay, so what do we learn from this case is that core binding factor leukemia includes AML with CBFB-MYH11 and AML with RUNX1 and RUNX1T1. KIT, RAS, NRAS, KRAS, and FLT3, both TKD as well as ITD, are common to both AMLs. Loss of sex chromosomes such as X and Y, mutations in chromatin modifiers, transcription factors, and coenzyme complex, on the other hand, are unique to AML with RUNX1 and RUNX1T1. So let's look at the fifth case.
So case 5 is that of a 2-year-old male child, leukocytosis and blast in the blood.
Okay.
So for me, this appears like a hypercellular bone marrow aspirate picture showing erythrocyte, megakaryocyte, and series. So this is a peripheral smear picture showing more than 20% blast. What I can see is large cells with large nucleus showing granular cytoplasm, prominent nucleoli. This is again a blast, and here I can see an odd rod, sir, within the cytoplasm.
Wonderful. And do you think these are positive for MPO?
So I think they are positive for MPO.
Okay, what do we see here?
So over here I see CD34 and CD13 are dimly positive. CD117 and CD38 both are again dimly positive. HLA-DR is positive. CD123 and CD is negative. CD33 is dimly positive, sir.
What about CD7?
CD7 is negative, sir.
So it's variable, no? You can see that it's coming all the way from positive to negative. Okay. And what's happening here?
Sir, I think CD15, CD7 both are positive.
So they are co-expressed. All right. So based on this, what do you think is the diagnosis?
Sir, it is probably AML, more than 20% blasts, and immature forms are more, I'm thinking.
Okay, so CD7 positive and CD15 positive and CD34 positive AML is very likely to be AML with biallelic CEBPA mutations. Okay, this is the classical phenotype, and I want you to remember that 7 and 15 being co-expressed in myeloid blasts is very suggestive of CEBPA mutated AML. Important thing to note, at least in my experience, is that these CEBPA mutated AMLs have sharply punched out nucleoli. All right, what you can see here, and they can show the presence of all, or sometimes these cells can be slightly hypogranular, but dysplasia is not a prominent feature. So what do you see here?
So here, honestly, I could just make out the type of mutations that is insertions. I cannot make out.
Okay, so that's right. So you have the CEBPA mutation, and there are how many CEBPA mutations?
2 CEBP.
There are 2 CEBPA mutations. All right, so you can see that there are 2 CEBPA mutations that are there, and a RAD21 mutation. So what's happening here?
So this is again CBPA associated with both TAD1 and VZ domain. So it is biallelic.
Very good. So this is an assay known as a fragment length analysis, right? You do a PCR, and if there is a normal person, like you are a my blood, if you do a PCR, you just get one wild type peak of 316 and 507. But if there is an insertion of a particular base, you'll get 2 bands, because there is a normal size peak and another mutated peak or mutated band in which 1 base is increased. Similarly, here you can see 3 bases are increased, and you'll get 2 different bases. So this patient has a 1 base insertion in TAD1 gene and a 3 base pair insertion in CBP. So what's the hematpath diagnosis?
So AML with biallelic mutation, if you can call it so.
Yes, very good. And does the NGS result influence prognosis?
Yes, it's a good prognosis. It shows good prognosis.
Okay, what is the importance of this diagnosis? So it is important because it's a favorable risk AML. Would you like to give any advice to the patient?
Again, I think so I'll just help with the therapy so we can.
That's it. Would you like to ask the patient any history, any findings? Would you like to know?
I'm not sure. Sir.
Would any of the other students want to comment on this? No, nobody. No advice to the patient. No history that you would like to know for such a patient.
Any familial syndrome?
Yes. What kind of familial syndromes? Please, can you be a little bit more specific? You're right. So okay. So let's look at things more closely. All right. So this is a related case.
So it is that of a 20-year-old male, leukocytosis, anemia, and thrombocytopenia.
Okay. And what do you see here?
So I can see a hypercellular bone marrow aspirate picture, and I can see increase. So for me, these appear like mostly monoblasts, monocytic towards monocytic lineage because of the vacuolations in the cytoplasm.
So they are blasts, they have abundant cytoplasm, and they have sharply punched out nucleoli. And they are MPO negative. So this is an AML. Now what do we see here? This is the only change that this patient has got.
So this is just a single allele that is involved, sir.
So this patient has a 3 base pair insertion in the zip domain. All right. So you can see a normal peak and a mutated peak. So how does this case differ from case 5?
So again, that was biallelic, and for me, this is single allele that is affected, and that appeared more of myeloid series, and for me, this is appearing monocytic.
Okay. Yeah. Okay. Does the NGS result influence prognosis?
Yes, sir. Again, this will be a moderate to poor prognosis.
Moderate to poor prognosis. Okay. All right. So, and the importance of this diagnosis is that what?
So prognosis and again therapy.
Okay. So would the rest of the students agree? Would you have anything else to say here? Anybody has any comments to make on this case, or okay, let's just go ahead. All right. So CEBPA mutations are traditionally associated with favorable outcomes in AML, and you can see that these are TAD1. These are typically, this is a single exon gene. All right. This gene is involved in normal myeloid development. So as cells start to mature from blasts to granulocytes in every patient, this gene expression of CEBPA increases, and you can see as it starts to terminally differentiate, the expression goes down. There are 3 domains. Domains means areas in the gene. It's a single exon 1.6 kb gene which has got TAD1, TAD2, and ZIP domains. And there was this seminal paper which showed that patients with mutant CEBPA have better outcomes as compared to rest of the other AMLs. But these mutations are not actually one and the same. All mutations that are present in the TAD1 domain have to be looked at carefully, because a fraction of these patients are actually germline mutations. So who can tell me what's a somatic mutation and what is germline?
Somatic mutation is the mutation which occurs in the tumor, but germline mutation is present on all the cells.
So a germline mutation develops as a result of normal growth and development. It is inherited typically from mommy or daddy. All right. Whereas somatic mutations originate from the soma or the body and is typically seen in tumors or cancers. Okay. So 10% of these mutations in TAD1 in CEBPA, especially TAD1 mutations, are likely to be germline. Now this is a large series of almost 4,000 patients who compared patients who had CEBPA mutations. Can you all see this? Either biallelic SEPA or ZIP mutations and TAD mutations. And what you can see is that these patients are likely, especially patients with biallelic SEPA and ZIP mutations, had similar mutational profiles. They had mutations in GATA2, they had mutations in TET2, they may have mutations in WT1 in both of them, but not so. But here it is slightly different. What these patients actually found is that patients with biallelic SEPA as compared to wild type AML or single mutant AML had favorable outcomes. All right, what you can see in this picture here. And these patients' outcome was similar to that of biallelic SEPA. So if you have a patient mutation with ZIP domain, single mutation in the ZIP domain, or biallelic SEPA mutation, the outcome is comparable or is favorable as compared to rest of the single mutant CEBPA. So this has resulted in changes in the WHO classification that only patients with biallelic mutations or with a ZIP mutations are likely to be called SEPA mutations. Single domain mutations outside of CEBP, outside of ZIP, do not matter. Okay. And another important thing to remember is that 5 to 10% of patients with biallelic SEPA, especially TAD1 domain, have germline mutations. So you have to counsel these patients to send their germline, to send for germline testing. We do this in all biallelic SEPAs we see here, and we have 3 cohorts of patients in which the CEBPA mutations are present within their families. Okay, so biallelic SEPA has distinct biology, immunophenotype which is 7, 15, 34, co-positive. It has favorable outcome. VZIP domain SEPA mutated AML also has a favorable outcome. 10% of biallelic SEPA gene mutations have got germline mutations, and they must undergo germline testing. Last case, who wants to speak?
Hello.
Dr. Arab, who's that?
Yes, sir.
All right, go on, please.
16-year-old male with fever, weakness, and the last body ache is 1 month. Thalassemia in thrombocytopenia.
Okay.
This is a hypercellular particulate bone marrow smear.
Okay.
And
what do you see here?
This is blast.
Okay. There.
MPO positive. I think
they're MPO negative. So these are actually controls, normal granulocytes. You can see that there's virtually no MPO in them. These are MPO negative blasts. Okay. And what do we see here?
This CD45 positive.
Okay.
And CD117 negative and CD34 negative.
Very good.
And in this case, we say CD8 negative and CD4 positive.
Okay.
And CD33 and CD64 both are positive.
Okay.
And CD56 and SLADR both are positive.
Would you say that this is in particular region of the CD45 side scatter plot, any particular region? So there is expansion, slightly there is some expansion towards the monocytic component, which you can see here by CD4 positivity, also by bright expression of CD64, right? So I would suspect that there is some monocytic differentiation. Now what's going on? What cells are these?
These are the fast precursor cells.
So these are histiocytic fragments that you see here, okay?
And
what's this?
these are the blast cells in which there is extra cells. I think it is phagocytosis.
So there is some, you're very, very right. So there is some amount of phagocytosis that we are seeing here. And this is a phenomenon, especially this, in which one cell passes to another. And it's called as tumor entropy. Okay, tumor entropy. That means one cell passing through the cytoplasm of a tumor. It's called as tumor entropy. Now, what do you think is the diagnosis? So, of course, AML. But beyond that, do you think there are any additional features observed?
Sir, hemophagocytosis.
So some amount of hemophagocytosis, tumor entropy. Now, do you know of any tumor that, or AML that produces this?
Acute myelomonocytic leukemia.
Well, we've seen so many, but does it actually produce hemophagocytosis and tumor entropy? So not really. Okay, so let's go into this. This this is a bit of a difficult diagnosis. So blast express moderate 64, 33, 4, 56, DIM13, variable HLA-DR, and you're right, it is AML with monocytic differentiation. When we did RNA sequencing on this, we identified a translocation 816, CAT6A, CREB-BP fusion. So these CREB-BP fusions typically, so MIS3 is the old name, new name is CAT6A. These typically occur between exons 15, 17 and exon 2, 4 and 5, 2 to 5 of CREB-BP gene. All right, these patients are associated with, see this, some sort of tumor entropy, hemophagocytosis, erythrophagocytosis. They are positive either for MPO or NSC. All right, and this is a series that has been published in AJCP. You can see that these were 13 patients, and half of them had therapy-related AML associated. Okay? And these patients are associated with poor outcomes. So these patients, irrespective of whether they were treated with chemotherapy or transplant, their outcomes were quite bad. And in those patients, if those patients had secondary or therapy-related AML, they did even worse. So the prognosis of these patients is poor. They're rare. Death of patients, half the patients occurred in first 10 months due to infections or bleeding. Okay, so fusions are important in AML, especially with the new WHO classification, except for AML with BCR-ABL1. If you have fusions, irrespective of the blast count, stage becomes stable. Now, these particular patients are associated with the phenomena of hemophagocytosis, or in some cases, tumor entosis. And these have myelomonocytic features and associated with past chemotherapy. So last case is a 31-year-old male with anemia leukocytosis. So who's going to speak on this?
Yes, sir. 31-year-old male presented with anemia, leukocytosis detected on CBC. So this is a PBF showing the leukocytosis with increasing blast, having high NC ratio, immature fine chromatin, round nuclei with some showing indentation.
Okay. And these blasts are?
Yes, sir.
What do you think the stain is here?
So this is Sudan black B stain.
Okay, so we don't use Sudan black B. This is myeloperoxidase, and myeloperoxidase is positive. So just out of curiosity, what do you think is the better stain, Sudan black B or myeloperoxidase? Why?
Myeloperoxidase?
Yes, but why? So myeloperoxidase is a better stain. It is more specific. Sudan black B can be seen in some amount of ALLs, and it has lesser specificity. Therefore, the WHO does not give any importance to Sudan black B. All right. Okay. And can you talk about the flow for these patients?
Yes, sir. This is 38 and 34 positivity is there.
So only a subset of them are 34 positive.
34. Yes, sir. CD117 positivity is there. CD7 negative. Okay. Then CD15 positive and CD13 also positive. Okay. CD64 and CD33 both are positive. HLA-DR positive is there. Then CD11B negative.
Now what's happening here? This is a more difficult thing to state. What's happening here?
So this is genome-wide copy number alteration. This analysis reveal a partial gain in the chromosome 11.
Okay.
So below there is abnormality noted in the KMT2 in exon 27.2 to 27.36.
All right. And what do you think that abnormality is?
So there is a gain in the copy number.
So how did you reach that conclusion? So from 27 to 36, that means on this side of the genome you are seeing a gain?
Yes, sir.
So actually this is normal. Okay, what you see here is this is how the rest of the KMT2A gene looks like. And between exons 2 to 8, what you see here is that there is a gain. This is normal, and this is 0.5 log limit. That means 0.5 log above or below. And you can see that there is a large amplification in exons 3 or exon 2 to exon 8 in KMT2A. So what is the diagnosis, and does the NGS result influence prognosis? What is the importance of this?
On the basis of morphology, acute monocytic differentiation, then it may be AML with translocation 911.
911, why?
KMT.
So is the only abnormality in KMT2A that's known, is that of a translocation?
No, sir. We can have more also.
Like what?
So 11-9.
Okay, so you can have translocations, but okay, so you can have translocations, but what we see here is that this patient has something known as a partial tandem duplication of KMT2A or the MLL gene. All right, so when you say of partial tandem duplication, it is not a translocation. But you can see if this is the KMT2A between exon 7 and 8. In what happens here is that the region between 3 to 8 actually gets duplicated and reinserted back into the genome. So you can see that there are many copies of 3 to 9, and again there is 3 to 9. All right, followed by the rest of the gene. These are known as repetitions of the genome, which are detected by copy number analysis. You've heard of the term amplification? You know that CRB2 in breast cancer undergoes amplification, right? So this is a type of amplification or a copy number alteration, which can be detected by CNV or copy number variation analysis. This is known as partial tandem duplication of the MLL gene. It occurs in 5 to 6% of AML, especially in normal karyotype AML. Quarter of patients with trisomy 11 have partial tandem duplications, and these patients have a shorter overall survival and disease-free survival. These are associated with DNMT3A, IDH2, and IDH1 mutations, and they are associated in at least some cohorts with inferior outcomes. Now, how do we treat AML? How do we prognosticate AML? So for that, I would like to refer you to the ELN risk stratification. Now, any patient with FLT3, irrespective of the allelic ratio, comes in intermediate prognosis. Any patient who has mutations in TP53, RUNX1, or in the 8 genes that are associated with MR comes in adverse risk. Conventional. high-risk cytogenetics patient also come in, monosomal karyotype also come in this group, all right? And this has very inferior outcomes. Patients with RUNX1 mutated AML are specifically important as they have very terrible or inferior outcomes. So what do we learn from this case is that AML is biologically heterogeneous. It has chromosomal and structural abnormalities. You can have gene fusions like 821. You can have gene mutations such as NRAS and KRAS and so many different types of mutations. And next generation sequencing provides theranostic information is essential to the work of AML. With that, I'd like to say thank you, and we'll be happy to answer any questions if
Thank you, Dr. Nikhil. That was a great and sublime presentation. With that, I'll invite Dr. Balsab to give his comments, and then we'll take up some questions after that.
Yeah, thank you. I think it was really great to hear Nikhil. And no, as you would have understood from him, that AML diagnosis has become more complex, and it is for a reason. The way it was treated in 2010, I can see is clearly 3+7 induction and HiDAC and transplant for high-risk people. So it was really not much of option. But with now options available, it is important to have risk categorization. It is important to have a comprehensive workup, as Nikhil said. Even in a defined entities, there are sub-entities, and you are having a smaller subset. And he also pointed out some of them are targetable. For example, FLT3 mutations, IDH mutations, and also with the newer drugs, you have improved outcome. So definitely, it is an important part. And AML has a very special place in any oncology or any hematology setup. If you are able to manage AML patient, you will be able to manage any oncology. And now I think the next thing is if you are able to diagnose a AML patient properly and stratify, probably you'll be able to manage them. And with that, I will pass on to you. And one comment, Nikhil, you teach very well. I enjoyed listening to you, and I also learned things are rapidly changing, so it is important for clinicians and pathologists to have a dialogue. So over to you.
So we have a few questions. One of the questions is there any treatment difference for AML with blast crisis with AML with BCR APL?
Dr. Balsab, that is the best person to answer.
Yeah, so clearly the AML with translocation 922 is a high-risk entity, and these people, they behave differently than the CML blast crisis. CML blast crisis, most of the times you now see is the de novo. Chances of them progressing on treatment is very less. So one thing is the kind of TKI which you are going to use is probably different, because CML BC would be exposed patient, and the other AML with 922 would be naive patient. Second thing is their outcomes. Since they are TKI naive in AML with the Philadelphia chromosome, probably they are going to do a shade better than the CML blast crisis. The treatment would be chemotherapy with a tyrosine kinase inhibitor and followed by consolidation allogeneic transplant.
Okay, so Dr. Nikhil, there's a question for you. When you were showing, I think case third, you were explaining the nomenclature. So one of the students want to know, what does the NM mean when you're showing an exon?
To understand what is NM, you need to understand the concept of RefSeq. RefSeq was an NCBI's objective to develop a standardized nomenclature of genes. See, one particular gene can have several different transcripts. So when you say IDH1R140Q, if the reference transcript changes, the numbering or the codon amino acid numbering will also change. So between the different authorities of the world, mainly the Ensemble group in Europe and the NCBI group in America, they have now come to something called name select, wherein all they refer to standardized nomenclature. So when you talk of one particular transcript of a gene, you refer to it by NMID. So NMID refers to the transcript, NCID refers to the chromosomal coordinate, NPID refers to the protein coordinate, protein and amino acid nomenclature. All right. So when you say NMID, it is I'm looking at this, but you have to say that this is the NMID of the gene. So I'm nomenclating this particular mutation based on this transcript.
Okay.
I hope that answers the question.
Yes, sir. Yes, sir. So thanks for very wonderful talk, sir. And I'm sure students have enjoyed it a lot. And with that, we come to the end of the session, and we'll meet